Thank you very much, Peter. So thank you very much to the organizers to invite me to be here today and to present to you a couple of things about tuberculosis. So what I'm not going to do is give you everything you always want to know about tuberculosis, but we're afraid to ask. I'm going to focus it on TB-HIV. I thought that was for this audience the most appropriate. And the perspective that I will take is this one. So if you look at the estimates of mortality due to HIV globally, that estimate by WHO is around 1 million deaths per year. If you look at the estimate of TB mortality among HIV-infected patients, that is almost 400,000. So that means that almost 40% of all deaths due to HIV are estimated to be due to tuberculosis. Now, this is a problem, given the fact that we have I think, pretty well controllable infection now with HIV, and we have a treatable disease. But the combination of these two apparently brings still a lot of challenges. And I'm going to take the perspective of the cascade of TB care. So you will see here those who have HIV, who have tuberculosis disease, those that are tested for TB, those that are diagnosed, those that are diagnosed and start on treatment, or start on treatment without diagnosis, and those that in the end are cured. And of course, if you somewhere drop out from this cascade, you have a very high mortality. That's basically what it means. So this is what we need to address. And of course, this cascade is actually much larger. So there is two huge bars that come before this. This is those that are TB infected, and of which a large proportion in HIV, especially with low CD4 counts, progress to having tuberculosis disease, but of course the much larger bar even of those who are TB exposed. So this is about transmission and about prevention of disease in those who are infected. But I'm going to concentrate on this one here for this audience, and I'll say just a few words about the other ones at the end. So let us start at the far end of cure. So this is the question of how well are we doing in successfully treating HIV-TB patients. And the problem is that we actually don't know. And this has to do with the fact that so many TB patients, often for very good reasons, are started on TB treatment without a bacteriological confirmation, so without a bacteriological diagnosis. This is called empirical treatment. I'll say more about that later on. But this is one of the difficulties. Now, we know, obviously, that early antiretroviral treatment reduces mortality in HIV-TB. This is what we know. And we know that this is especially the case with low CD4 counts. And this is data from, you're probably aware of this, of a meta-analysis that was done of the 8 randomized controlled trials that had been done. And especially on the upper part there, you will see that it is especially effective in terms of reducing mortality up to 30% in those who have very low CD4 counts, below 50, much less, actually hardly so in the ones who have high CD4 counts. But despite that, we still have this high mortality, even though it's difficult, again, to really get a handle on that numerically. There is the indications that we have that mortality is still pretty high comes, for example, from this trial of a diagnostic, actually of adding this particular diagnostic, which is a lateral flow test for lipoarabinomannan in the urine, to the diagnostic algorithm for TB. And what I want to draw your attention to in this trial is that there were 2 arms. There was an arm in which patients got, in addition to other diagnostics, got this particular test, and that is in this arm, and the other one, they didn't get that test. But the thing I want to draw your attention to is to the upper line here, which says that those who were started on tuberculosis treatment, of those still 20% in that arm died during treatment, which is still very, very high. And interestingly, if you look at the patients who were in the other arm, which didn't have LAM, it was more or less the same, well, hardly a difference. So this is an indication that mortality is still very high. Another indication comes from the one here on the bottom, which is a cohort study that was spearheaded by the late Steve Lawn, and that looked at mortality among HIV-infected TB patients who were diagnosed with TB, so confirmed tuberculosis, who were treated by their urinary LAMP status, and as you can see there on the bottom, that about 38% had a positive test, and that is strongly correlated, we'll see more about that later, with low CD4 count. So it's a reflection of sort of severe disease and poor immune status. And you will see, and that is here on the top, let me see which one I have to, this is the better one. You can see here that here mortality still goes up to 20% or more. So mortality is still very high. Which means that in terms of challenges, the real question is how can we improve survival of TB HIV patients who have low CD4 counts? It may be that we need to provide better general clinical care. These are usually very ill patients, for example, do better in terms of treatment of TB iris. It may also be that we're missing other opportunistic infections that are there at the same time. There's some indications that cryptococcosis may be missed in some cases. And perhaps it's a matter of adjusting the dosing of TB drugs. For example, because there may be drug-drug interactions, but also because we know that there is reduced bioavailability. And there's actually been a small study that suggested that in these patients with very low CD4 counts, increasing the dose of rifampin actually improved survival. So let's look at the next step. And we'll take the group of TB diagnosed and treated together. So this is out of those who are tested. What has really changed the world is this assay. This is GeneXpert MTB-RIF. You probably know about it. It is a within cartridge PCR for which no PCR lab is needed. Has limited training requirements. You get the result within 2 hours, and importantly, it also tests for the most important drug with regard to definition of multi-drug resistance, which is rifampin. So it's a great test, and it has been shown to be a great test. I have no conflict of interest here. Let me assure you. This is data that came out from the very early field studies, which showed that compared to smear examination in the HIV positives, the sensitivity of the test was much better. That was later confirmed, what you can see on the bottom, in a meta-analysis of a large number of studies, which showed then, again, very much on the bottom, that the sensitivity for HIV-positive patients is not significantly different from that in the HIV-negative patients, and is on the order of 80%. So that's great. The important thing still is that among those patients who have smear-negative tuberculosis, when you compare it to microscopy, you still see that the sensitivity is far from perfect. And there have been numerous studies done also of extrapulmonary TB, so looking at non-respiratory samples, and this gives you the overview. You can see that specificity is generally good. Sensitivity is very much depending on the kind of specimen, as you can see on the bottom. I think the important thing here is if you put the bar pretty high with regard to the reference standard, then you can see that for lymph node tissue or aspirates, the sensitivity is pretty good. It's 84%. But it's much lower, it's very low for pleural fluid, and for cerebrospinal fluid, it's more or less in the middle. It's 56% reasonable, but not perfect. All these data led to recommendations by WHO. Test was first endorsed in 2010. That was later updated in 2013. And these are the recommendations. So it's a strong recommendation to use XPERT as the initial diagnostic test for adults and children suspected of MDR-TB or HIV-associated TB, and on CSF from patients who are suspected of TB meningitis. But in addition, if resources allow, then it is also recommended to be the initial diagnostic test for all adults and children suspected of having pulmonary TB and all patients suspected of having extrapulmonary TB. In the meantime, there's also been this endorsement of a test that got pretty little attention, I think. That's the TB LAMP, which is an isothermal PCR, which has a sensitivity which is not much worse. It's more or less the same as for XPERT. It has a couple of disadvantages in terms of potential for cross-contamination. Another disadvantage is that it doesn't test for rifampin resistance. And you can here see the recommendation to use it for adult patients, but not to replace XPERT. Then there is this assay that I've already mentioned. This is a lateral flow test that tests for this particular cell wall constituent of Mycobacterium tuberculosis in urine. Now being recommended as an additional test in HIV-positive patients with low CD4 counts, and we're going to see why. And then, and I'll pay some attention to that, there is now a new kit on the block, which is XPERT Ultra. The introduction of GeneXpert has really taken off, over the past few years, and that has shown us a couple of things. Now, the first thing is that the trials that have been done, the pragmatic trials, they suggested that, yes, it increased the number of patients who started on treatment with bacteriological confirmation, but it did not increase the overall numbers of patients who start on treatment. So it didn't really increase case finding. And I think important for this talk here today, it didn't clearly reduce mortality. So this is from a paper that is now submitted. This is an individual participant data meta-analysis from the 5 randomized trials that have been done. And as you can see here, this is looking at all-cause mortality in all patients. You can see that there is a hazard ratio of 0.83, but it's not significant. It is better in the HIV-positive patients, significantly decreased mortality here with this hazard ratio, but probably with 6 months of treatment, probably the more appropriate measure is the 6-month cumulative mortality, and then you can see that that is less and is also non-significant across those 5 trials. And why is this? And this has to do with the high rates of empirical treatment. So many patients, especially in HIV patients, not only, are treated based on what we call clinical diagnosis or empirical diagnosis, which is without bacteriological confirmation. And this has been shown in these trials, in all the trials, not only in the African trials, but also, for example, a trial in Brazil, where relatively small numbers of HIV-infected patients were included. And Grant Theron, who did the first trial, wrote a viewpoint paper a couple of years back in Lancet Infectious Diseases, where he said, well, what we would like expert to do is to reduce overtreatment, because it has a higher sensitivity. It should convince doctors that if you get a negative test and you don't have a very, very strong clinical suspicion, that you shouldn't treat for TB. And this is how he sort of depicted it. So in the end, what you would like to see with introduction of expert is that more patients, the blue ones, who are treated for TB are so with bacteriological confirmation. But that clearly hasn't happened. And then the question, of course, is overtreatment harmful? Well, I think there is some data to suggest indeed that is a problem. This is observational data. It's not the only study, but I think it's a recent one. It's done by Sabine Hermans in our group, looking at patients in Uganda, over 300 patients that had been tested with experts, and then they looked at what the clinical decision had been based on the test result. And here you can see, so this is confirmed. So these have the positive expert are treated. These have a negative expert are not treated. These have a negative expert are treated. So you can actually see that mortality is higher in that large group, which probably is a reflection of the fact that these patients are more ill, but also may have other diseases that remain undiagnosed when they start on TB treatment. So that is an issue. Now, there have been clinical trials to look at this issue. And the one that has been reported in the literature is the REMEMBER trial, but the ACTG trial. That's a trial of empirical TB treatment. That was a trial in 10 countries. It included patients with CD4 counts below 50 who were initiating ART. And the arms were empirical full-course TB treatment versus isoniazid preventive treatment. The primary endpoint was mortality or unknown vital states at 24 weeks. And here you can see that there was actually no effect. There was no effect on mortality. Now, the problem with this trial is this one here. It's who were excluded. So basically, this trial excluded patients who had confirmed TB for obvious reasons, but also those who had suspected TB, which actually went quite far. So if patients had symptoms that were suggestive of TB, they couldn't be included in the trial, which actually means that this trial gave a definitive answer to the wrong question, I think, because the patients who would benefit most potentially from empirical treatment were not included in the trial. This is my own personal opinion. Other trials have taken a different point of view, and this is the one that I was involved in. That's the PROM trial, which was done in 3 countries, which actually tried to look at those patients with very low CD4 counts, with very low BMI. So these are the very sort of ill patients, high suspicion of tuberculosis. In the 2 arms, it compared TB treatment followed by ART with ART only, looked at all-cause mortality at week 24, and included patients who are suspected of TB, but of course not those who are smear positive, and also not those who are sort of designated as smear negative. And we had to stop the trial. And the reason why we had to stop the trial is it was very difficult to include patients, because when we started the trial, there was a reluctance in these African countries to treat patients who had a negative smear who were HIV positive for tuberculosis. By the time we had started, the mood had changed and doctors actually started doing this at large scale. So basically the diagnosis of smear negative TB includes those who get empirical treatment. So there's a catch-22 situation here. The status trial, which is an ANRS-funded trial on the right, that hasn't reported yet. It takes more or less the same approach. And then in the middle is TB Fast Track, which was a quite different trial, which actually had as the intervention arm patients who were considered to be at high risk, which was defined as low hemoglobin, low BMI, or they have it again a positive LAM test. And that showed some effect on the mortality at week 24, but that was not significant. This was reported 2 years ago at CROI. Then the question is, what happens at the population level? So after expert has been introduced, has it done anything on empirical treatment at the population level? And this is data again by Sabine Hermans from South Africa, now looking at routine TB notifications in Cape Town over a period of 5 years, 100,000 patients, where expert was introduced from 2011, the second year here. And what you can see is that in the HIV-negative patients, empirical treatment rates went down to 23%, from 23% to 11%, and HIV positives even from 42 to 27%. So this is actually what you see here is the empirical treatment that went down, total notification of patients that went down, and this is the number of patients with bacteriological confirmation that went up. So yes, over time you see that doctors apparently, when expert is being used and comes back as negative, will more often say, well, maybe we should wait to start this patient on treatment because I don't have this very strong suspicion that the patient actually has tuberculosis. So the other issue, or it's very much related, so what we actually need is higher sensitivity tests. We need to tests that better convince a treating physician that this patient, that if the test comes back negative, the patient actually doesn't have tuberculosis, especially in those patients with low CD4 counts. And this is, now here you have this test that I mentioned before. This is the lateral flow test on urine. There have been studies that looked at what would happen if you combine this test with GeneXpert. The reason to combine it is what you see here on the bottom, is that the sensitivity is strongly dependent on the CD4 count. In high CD4 counts, defined as above 200, the sensitivity is below 20%. When you go down in CD4 count to below 50, the sensitivity goes up to around 65%. So it's a reflection of low CD4 counts and a couple of other things. So that if you add this, so basically this is what the gap is with GeneXpert in terms of diagnostic sensitivity. So if you add that, you do see, that's the green bar here, you do see some increased sensitivity. And have been, and the other thing that is worth mentioning is that it is a strong predictor of mortality in the HIV infected. And this is from a systematic review. And here you see a separation between those patients who ultimately have high mortality, that's on the top, against patients who ultimately have a lower mortality. Well, I think neither of them does it, functions. On the bottom, and you see it's more or less the same pattern. So there is a clearly increased relative risk of mortality in those who have a positive LAM test. So this is again this trial by Peter, published in The Lancet 2 years ago, which was a pragmatic trial done in 4 African countries, includes symptomatic hospitalized patients, and compared LAM added to what I call optimized background diagnostics, which is smear, expert and culture, to an arm with only those diagnostics. Outcome was all-cause mortality at 8 weeks, and you see here that yes, there was a decrease in mortality, 18%. That was statistically significant in the LAM arm compared to the no LAM arm, and there was some heterogeneity in these outcomes. Interestingly, not for clinical stage, as you can see in the middle, but there was heterogeneity clearly for CD4 cell count and the country of enrollment. And I want to draw your attention to that, the best separation, even though not perfect, between those who benefit and those who benefit much less from having LAM added to the diagnostic algorithm is again in the CD4 cell count cutoff of 50. So the new kid on the block, in addition to LAM, is this test. So this is an improvement of GeneXpert. It's called the GeneXpert Ultra. It has improved sensitivity. They did some technological juju. This is data from a study that came out just this month in Lancet Infectious Diseases by Susan Dorman. They looked in 8 countries at accuracy in a head-to-head comparison with GeneXpert. 32%, so 1,500 patients, 1/3 of them are culture positive. And as you can see here, the Ultra does have a better sensitivity. This is in all culture positive patients. In the smear negatives, also a better sensitivity. Mind that here sensitivities are relatively low, which is because the bar was set very high for the reference standard, the 4 liquid media cultures. This is a problem in TB anyway. The more you test, the more you find it. That's the problem. It's a bit of a fluid reference standard. But you can also see that as sensitivity goes up, specificity goes down, which has to do with the fact that it has so-called trace calls, so there are sort of very low numbers of bacilli can be found, and you can see here that depending on how you take the trace call into account, sensitivity goes up, but at the same time, specificity goes down. So it is better, slightly better, but it still gives us this problem of whom should we treat. Another thing about this test is that it has shown to be very promising in TB meningitis. It's here comparing to Ultra to Expert with much improved sensitivity, also if you take a very strict case definition. So here the challenges are how to improve diagnosis of TB-HIV patients, especially those with low CD4 counts. It's clear that we have to do better in terms of empirical treatment, target that better in order to make it more beneficial. And clearly we need assays that have improved accuracy. There's quite a bit ongoing in that, in those terms. This was kindly provided by Claudia Denkinger of FIND. This is the pipeline for TB diagnostics, and you can see that from 2018 we're going to see a couple of things that may be promising. On the top there is a squeeze bottle for stool, and this is actually very interesting because it seems to be much more sensitive in children. It's always good to do stools in children. I mean, it may be difficult to get a specimen out of children, but you always get stools, even if you don't want to get it. So stools is probably a very good specimen. Stools may actually be a good specimen in those with very low CD4 counts, adults. I don't think that studies have looked at it at large scale, because it's a very large surface that's in contact with the circulation. So this may be an interesting one, and then there is a couple of other assays that are coming. So there is a next generation LAM point-of-care assay, there are blood host markers, and a couple of other things. I won't go into much detail, but there is light at the end of the tunnel here. Now let's move to the other one, which is who drops out for being tested for TB. And there I start with the challenges. So the challenges are really how to increase screening for TB among people with HIV. That's actually how can we best improve the functioning of the health system, because I think it's a system effect to a large extent, and can we do more with triage tests. So if you look at HIV testing among registered TB patients, it's data from WHO for the latest report, you can see that that's really gone up over the last few years, especially in Africa, but you can see that on the bottom there, that's Southeast Asia and Western Pacific, where 2/3, probably even 70% of all TB patients in the world reside. It is really far from perfect. It's around 50% of all patients who have TB who are tested for HIV at the moment. The other way around, so testing for TB among those who have HIV and are in HIV care, we have very little data on that. So it's very difficult to get a numerical handle on that. Although I think the general impression is that it's far too low. And you can think of so this is a matter of integration of services, and there have been, I think, a pretty good review a couple of years ago that looked at the literature and looked at the various models that were out there, and then you can see, so entry can be through TB services, can be through HIV services, and then so the better the integration is, probably the more effective it will be in terms of this cross-linkage between the two. For example, if you have completely separate facilities that would refer patients even for testing, it usually doesn't work. If you do the testing within, for example, the TB testing within the HIV care facility, then the results are already better. But probably having a single facility for both would work best. And a related aspect here is this. This is, I think, a very interesting observation. It's a study I was involved in Uganda, which looked at, very operationally, looked at the utilization of Gene Expert in 8 health facilities. And what it showed was that only 21% of patients with TB symptoms were tested. So even though we have a much better test, it's not being utilized. And there are a number of reasons why this may be the case. First of all, there is still, even with a better test, a very high threshold of clinical suspicion. It's difficult to get sputum. I think people shouldn't forget that. It's a difficult test in that sense. It's too cumbersome to test everyone who comes into the clinic with TB symptoms. There are simply very often too many if you cast the net wide enough. So if you take everyone who, for example, coughs. There are often stockouts. There is often need for sample transport because the machine is in a different facility. And then it's still expensive. It's still $10 per cartridge. So these are all health system constraints, which means, in my view, that expert-like assays, even ultra with its much better sensitivity, on their own at least, will not be the solution for expanding TB diagnosis to find more TB patients, whether or not they have HIV, and find them earlier in their course of disease, because it's a system problem. If you put a better test in a system that doesn't function optimally, it's not going to work. And what we need is tests. We need system changes, but we also need tests that allow those system changes. So we need point-of-care tests there where the patients are, but also what I think are the rule-out tests, so what we call triage tests. So these are tests with high sensitivity but a moderate specificity, can be used at point of care and are inexpensive, can actually say, well, this patient, we don't have to bother about tuberculosis. This patient, we do have to bother about tuberculosis and have to do additional testing. The triage tests, people have been thinking about what the properties, characteristics of such tests would be. CRP, C-reactive protein, was actually quite a good candidate. And now we have, recently came out, this study from Uganda that looked at using CRP, point-of-care CRP, as a triage test. And it's actually very interesting because they compared it, as you can see on the top, for sensitivity, that's against against Gene Experts. They looked at sensitivity, they compared it to the symptom screen for WHO. There's a set of 4 symptoms. If any of them is positive, symptom screen is positive. You can see that it comes actually comes close to that symptom screen. But the specificity, as you can see on the bottom, is much, much better. So the positive predictive value was calculated at 34%. So 1 out of 3 patients who have a positive CRP in this setting actually has tuberculosis. So that's very interesting. So you can much better target those who need to have Gene Expert or a similar test. So then finally, my final slides, because I see my time is up. The thing that I was not going to talk about, I'll just say a few words about it. This whole area is tremendously important. It's basically about how can we decrease TB incidence among people living with HIV. I think it's a matter of 3 things. It's a matter of improving early test and treat with ARVs, because that has been shown to be the most important preventive measure against getting tuberculosis. But also to increase coverage and completion of TB preventive therapy. That's an entirely different field of research where a lot is happening, but importantly also to reduce transmission, in particular nosocomial transmission, so better infection control. And that's where I would like to leave it. Thank you for your attention.